Imagine the same hospital procedure performed on the same day in two countries. In the United States, the bill arrives a few weeks later for around $10,000. In South Korea, the patient pays roughly $50 at the front desk and walks out. This is not a small gap, and it is not an exception. Across almost every medical procedure, from a simple emergency room visit to childbirth to cancer treatment, Korean patients pay a tiny fraction of what Americans pay. And yet Korean health outcomes match or exceed American ones on most measures. The story behind that gap is one of the cleanest natural experiments in modern public policy. Here is the comparison in plain figures. The United States spends roughly $13,500 per person each year on healthcare, the highest in the developed world. South Korea spends about $4,500 per person, less than a third of the American figure. And yet Korea outperforms the United States on average life expectancy, on infant mortality, on preventable deaths, and on patient satisfaction with the actual care received. Koreans also visit doctors far more often than Americans do, around 15 to 17 visits per year compared to 4. Same outcomes, less than half the cost, far easier access. The American debate often assumes that affordable healthcare must mean rationed healthcare. Korea is a daily counterexample. The mechanism is straightforward but rarely understood outside Korea. Almost every Korean is enrolled in a single national health insurance system called the National Health Insurance Service. Every employer, every worker, and the government contribute to one shared fund. That single fund then negotiates the price of every medical service, every drug, every device with hospitals and doctors directly. Because there is only one buyer for the entire country, the negotiated prices sit close to actual cost rather than market rate. Private hospitals still exist. Doctors are still paid as professionals, and patients can still choose where to go. There is no waiting list system, no government takeover of hospitals. The single difference is that nobody is allowed to overcharge because there is only one customer at the table. No system is perfect, and the Korean one has real strain points. Doctors are paid less than their American counterparts, especially specialists, which has been pushing many young physicians away from essential fields like emergency medicine, pediatrics, and obstetrics. Rural Korea has a growing shortage of doctors because almost everyone now wants to practice in major cities. Hospital reimbursement rates set by the single insurance system sometimes lag behind real costs, leading to periodic disputes between the medical community and the government. And because care is so cheap and easy to access, Koreans tend to overuse healthcare, which itself contributes to physician burnout. The system is excellent at delivering care affordably to the whole population, and it is fragile at the seams. What does Korea actually prove? It proves that universal access, low patient costs, and high-quality care can coexist as long as one entity is allowed to negotiate prices on behalf of the entire population. The American healthcare debate often gets stuck on the wrong question, asking whether the country can afford universal coverage. Korea suggests that the harder question is whether the country can afford fragmented bargaining, in which thousands of separate insurers face thousands of separate hospitals, and nobody has the leverage to push prices down. The Korean answer is not perfect, and it is not easily transplantable. But for any country watching its healthcare costs spiral upward, Korea offers something rare in this debate, an actual working model that has been quietly running for decades.